Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged today to be with Dr. Nishtha Sodhi. She is the Medical Director of the Valve Clinic and Program at University of Virginia. Nishtha, always nice to see you.
Absolutely, Chadi. Thank you for having me again.
So now you've been in the practice for a few years, not too many, but you are now Medical Director and you understand the hurdles and barriers to building a structured program. And we have a lot of programs now in the United States, graduating structured fellows. They're going to find a job. I see a small cohort of them have to start a program from scratch. So how we can give them the tips and tricks how to build a good structured program?
Yeah, so that's a very million-dollar question here. And I think really it probably can be broken down into two parts. One, of course, is having sound foundation in the medical skills, procedural abilities, and that, I would say, starts really from when a patient walks into clinic and understanding the evaluation process.
Right.
So, making sure that when you're a fellow in your structural year, you're really understanding even things like presentation, working up patients, and of course understanding the foundation of imaging and CT, whether it be 3Mencio or whichever software reconstruction, to really understand the procedure. And I always say that if you can own the CT of a patient and prepare using that CT, you really will have owned the case and will better position yourself to prepare for any anticipated complications or challenges during that case.
Yeah.
And I think during any sort of a timeout, sharing that with your team and staff, particularly when you're first starting off, I think allows the team to give you respect, and so that if, God forbid, some sort of a complication does arise, they are on board with the fact that you've shared that with them and that they can be prepared. So I think one bucket is, of course, having sound procedural and exceptional skills and knowing your patients and owning that piece, which comes from imaging as well, not just the actual procedural standpoint.
Correct, yeah.
I think the second big component that sometimes we don't always get when we're fellows, or is not as often as talked about though, is the leadership aspect of what is required into building a program. And I think that the best leaders, when we learn from our attendings, are those that can unify and bring together different subspecialties and areas of medicine and allow people to communicate freely for the best interest of the patient.
Yes, yeah.
And that is what leadership by example truly is, and it is so important in a structural heart team because oftentimes we have so many different folks, as you know, of course, surgery, anesthesia, our imaging, radiology colleagues, and then of course our nurses, our NPs, and that spans anywhere from the beginning of clinic where we're just meeting a patient for the first time, but really through their whole journey, through the pre-evaluation process, the procedure, their post-care and follow-up. And I think that being a leader is someone who can understand how to communicate effectively with everyone for the best interest of the patient. I think that when starting a program, a lot of fellows may get asked to join a position, as you mentioned, to do so. I think someone in that position, I think it's an exciting task, but also can be daunting because there are so many considerations, particularly from a financial and infrastructure and logistical standpoint that need to be well thought out. And so what I always say is that there should be buy-in from your colleagues and buy-in from the hospital administration.
Absolutely.
From a financial standpoint and also from a mission standpoint, so that everything is set up for success. Because there will need to be an initial financial investment from the hospital in order to support the creation of the program. And once that buy-in is there, then you know that the initial phase of trying to start something new is going to be supported. And I think that, there are, of course, STS and ACC and TBT guidelines about, of course, the minimum requirements to start, for example, a TAVR program and such in terms of volume. But I think the biggest things beyond those numbers when we look at is someone who can, be able to communicate with different members of the team to start that up and going.
So these are three important topics, as you said, buckets, I should say. Clinical skills, clinical and imaging, and also doing the procedure, but leadership also, you might need to be interviewing with a coordinator to hire somebody for the valve clinic, so to understand the credential of that person. So it's a lot of big burden in the beginning, but the most important thing, as you said, the buy-in from administration and colleagues. So you get the referrals
Right.
kind of streamlined, as well as the initial, allow me to say, the deficit at the beginning of this program. Because we start today, the first valve will be deployed maybe in 6 months in the best case scenario.
Best case scenario.
Best case
probably.
scenario, right? 6
Yeah.
months, 7 months.
Yeah.
But these are very important tips. So for structural fellows, now they are less involved, less busy, I should say, than interventional fellow, because they don't take STEMI calls and stuff. So do you recommend any studying, any courses, any building connection during the training, especially in the last few months before they graduate?
Yeah, that's a great question. I think that there's always room and role, whether you're a fellow or even early career, for courses like early leadership academies,
Yeah.
which are taking place at various hospitals. So that would be sort of one spectrum. The other spectrum, you could go as so far as doing a formal MBA.
Yeah.
But I think at minimum, what I recommend structural fellows to at least know about, particularly before they start their negotiations and as they're interviewing for jobs, is to understand the DRG system of reimbursement, particularly for TAVR, whether that's the 266 reimbursement with MCCs or the 267, and understand what goes into that evaluation and how billing and coding is done, and to understand how TAVR efficiencies can be optimized in order to really make sure that a hospital's contribution margin for each case is truly the maximum that it can be.
Yeah.
So understanding a little bit about how a service line works, what goes into the contribution margin of a TAVR or any structural procedure, I would say is at minimum just some of the framework that a structural fellow should have in order to be able to understand the language and the lingo, so that when they do get to their job, they're well prepared to have those conversations with their administration.
Absolutely. So negotiations, especially before they leave.
Absolutely.
Because they have to have a set in stone almost
Right.
expectation before they leave.
Yeah, and I think it looks good to be able to have that during an interview, so that you know what you're talking about and you sort of build and instill confidence into the team that's hiring you, that you are aware of the healthcare system and environment that we work.
Otherwise, you're going to hit the wall of frustration very soon.
Right, exactly.
Well, Dr. Sodhi, thank you so much for your time. Very useful tips for all the graduates for structural heart. Watch these videos and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you so much.